markers, this will resolve spontaneously. In literature or in textbooks, pediatricians, they are referring to this intermalleolar distance and intercondylar distance. So intermalleolar means you are measuring distance between two medial malleoli of tibia, and intercondylar distance means you are measuring distance between two femoral condyles, which is sign of varus, and intermalleolar distance sign of valgus. Now, in clinical practice, we have found that these two examination points are not very reliable. For example, if a child with Genu valgum, if the height of that child increases, and if this deformity has not progressed, then also the intermalleolar distance would increase. Or if we see a very hefty or fat child, they will like to widen their legs to accommodate the thigh fat. So again, in that instance, your intermalleolar distance would come more than normal, but that is not actual bony deformity. So we do not use intermalleolar or intercondylar distance in our clinical practice because there are a lot of variability and there are a lot of literature on it. What we measure is a tibio-femoral angle, and tibio-femoral angle is a more reliable examination tool. What we need to do for that? You have to make a child stand straight, mark an outline of patella, make a center point like this, and then there are 3 points which are important. One is the anterior superior leg spine, the bone which you can palpate over your above your thigh, little out. That is anterior superior leg spine. The second point is the center of patella, and the third point is the center of ankle joint. So the line which joins the anterior superior leg spine and the patella is the femoral axis, and the line joining the patella and the ankle is the tibial axis, and the angle made between these two is known as tibio-femoral angle. Now, those people who are very keen on measuring this or doing academic work, we tend to have this kind of goniometers with different handles, which can be used for children of different sizes. And for Genu valgum, we measure it in plus degrees, and for Genu varum, we measure it in minus degrees. Now, if you see this data of Indian children, most of the children, they have positive angle of 2 to 3 when they turn 2 years of age. So when you measure with this goniometer and you find Genu plus 2 or 3 degrees of angle, this is Genu valgum, and most of the children after the age of 2 years, they turn positive, and they reach the peak somewhere around 6 years, and they come back at around 8 years. And you can also see from this graph that girls have a little bit more Genu valgum compared to boys. But when you see that this thigh foot angle or tibio-femoral angle is more than 5 degrees after the age of 8 years, that needs to be investigated. That needs to be found why this Genu valgum or positive thigh foot axis is persistent, tibio-femoral angle is persistent. Many times the children are not stable and they are moving around. What we do in clinical practice, we ask parents to send across static pictures or videos. Now in the era of WhatsApp, it's very easy for them to take X picture on the smartphone, and they send it across just having underwears on, and they take pictures every 2 monthly and send to us. We review, and then if we find that there is for eyeballing, if their tibio-femoral angle is increasing, we advise them X-rays. Now these X-rays are also very important. We have to train our radiologists or technicians that these X-rays should be neutral. Neutral meaning their patella should be facing forwards. If they do not take X-ray in neutral alignment, they can fool us. A gross Genu valgum can look like a straight alignment. So the radiologist should be trained to take X-ray with the knee facing or patella facing forwards. For example, this boy with nutritional deficiency rickets and Genu varum at 2 years, we advise on standing X-ray. What we do in standing X-ray, we draw mechanical axis, an axis which joins the center of the femoral head and the center of ankle. And this axis is the weight bearing axis of the child. So whenever this axis is passing inside the knee joint, this is varus alignment. And if it is passing outside the knee joint, that is in valgus alignment. So we measure this mechanical axis, which is most reliable way. And we take these x-rays when we see that the pictures which patients sent across are showing gross change in the alignment. And most of the nutritional deficiencies where they have rickets, when we treat the metabolic disease, uh, by the age of 3.5 years, most of them neutralize or they become straighter. And for an example, this baby's mechanical axis, which were passing to inside the joint with the metabolic treatment, the mechanical axis are now normalized. So this is how we follow them. Now, if you look at this boy is having significant deformity, and we term it as an O deformity. With X-ray, it's difficult to differentiate it from the Blount's disease, but we tend to treat the metabolic parameter and we wait, and without any treatment, this boy has improved substantially. So for any sort of Genu Varum, after 2 years, we have to investigate and treat. And if it is nutritional, most of them, they improve by the age of 4 years. After the age of 4 years, if they do not improve, we tend to do some surgical intervention. So the question for pediatric colleagues is when to refer a child with Genu Varum. When the deformities are progressive or when deformities are asymmetric, one limb is affected more than the other, or when the deformities are not expected for that age. For example, if a child of 1.5 years has significant Genu valgum, ideally in that age group, child should be in Genu Varum or bowing alignment, or the vice versa. If a child of 8 years is in persistent Genu Varum, then this needs a referral, or when there are deformities are localized like Blount's disease. And most important, the reason why people refer this patient is that parents are very apprehensive. So that also it's fine. We like to kind of reassure them. So similar child, 7 years old, hypophosphatemic rickets diagnosed at our bone health clinic by our endocrine colleagues. And her varus is not acceptable. We did growth modulation and we could correct her alignment. Similarly, this boy who presented at bone health clinic, we diagnosed as metaphyseal chondral dysplasia. At the age of 3 years, he had significant varus. We advised an operation and parents failed to follow up. They came at 7 years with this prosthetic deformity. So it is wise to treat them early. Of course, we had to do multiple osteotomies to make him straight. But again, this boy at 2 years, at 3 years with significant bowing, I would advise surgery at the outset. Similarly, Genu valgum. Now, Genu valgum, these two boys presented to my clinic last week. And as you can see, both of them have knock knees. The key thing is the boy A was 2 years old and boy B was only 4 years old. So, and you can see that the 4-year-old boy is quite short compared to 2 years. And so height measurement is also very important. And we know now that a 2-year-old boy can have a little bit of beginning of knock knee alignment. So, we diagnose at 2 years as a physiologic Genu valgum. Now you see the intermalleolar distance which I have measured in these two children. This is the same distance, but although the deformity in child B is more, the intermalleolar distance is same because the height of child A is more than height of child B. Thus, the intermalleolar and intercondylar distance can fool us. So it's better to use a Tibio-Femoral angle than the intermalleolar intercondylar distance. And these are their X-rays that child A is having physiologic deformity and child B is having epiphysio, metaphyseal, skeletal dysplasia. Now, we tend to wait for some children with knock knees and we investigate, but this 4-year-old baby who was having significant knock knees, you can see there is widening of metaphysis of wrist. Child is irritable, not bearing weight. Her history was also like she had multiple deformities and multiple fractures in early childhood. Her dentition was delayed and she already received multiple dosage of vitamin D, and her growth chart showed she was pretty short, less than third percentile for their height and weight. And her x-rays are also showing a resorbed bone, both the extremity x-ray, and our endocrine team, it was diagnosed as a VDDR type 1 rickets. Now here, being an orthopedic surgeon, although the deformity is progressive, we should not jump on the treatment, because any surgical treatment you want the underlying metabolic parameters should be normalized first. So this was treated by our team, and once the bone health normalized, we did growth modulation and corrective surgeries, and this child got better, straighter, taller, and less irritable now. So if sometimes when the deformities are more for that age, we have to investigate about that bone health or underlying disease. If bone health is poor, we focus on treating the bone health first and then correct the deformity. So now let's go to in-towing. I hope that we'll take questions at the end, right, Dr. Agrawal?
Sure, sure.
Yeah. So in-towing, now this is son of a doctor, and who was referred to me, and he was seen by almost 3-4 consultants before me, and someone has told that his deformities are coming from hip, someone told that this tibia is what is responsible, and someone said it is the feet which are turning in, and they also seen a neurologist, and he said that a neuromuscular cause should also be ruled out. So when orthopedicians are confused, pediatricians are going to be confused, there's no doubt about it. But I'll tell you some tips and tricks of how to find out from where it is coming. So foot progression angle is the angle made between the long axis of foot and the midline. And if it is turning in, then it is termed as in-towing. It is turning out, then it is termed as out-towing. And when it is turning in, we term it in the minus degrees, and when it is termed out, we term it in the positive degrees. So in-towing has always a negative foot progression angle. Now we know that due to intrauterine positions of the limb, there are few physiologic rotational deformities a newborn harbors. One is femoral anteversion, or the thighs are turned in because of the shape of femoral head. Then second is the tibia are turned in, and third is the foot is turned in, or Metatarsus Adductus. So these all are physiologic, but at till what age we should consider them physiologic, that's an important thing. Now this concept I discussed last time, but I'll like to discuss it again. So at birth, what happens that this is the femoral head and this is the shaft of femur. This femoral head is angulated 45 degrees in front due to intrauterine positioning. And as the child starts standing, the frontal structures keeps on giving pressure on this femoral head. And so this femoral head angle reduces from 45 to 15 degrees by the age of 6 to 7 years. Now during this time, this is the front inclined femoral head. Only way to bring that within the socket is by turning the legs inside, or by in-towing, they bring the femoral head within the socket and they feel comfortable. They like to sit in W posture because they are comfortable that way. If you insist of sitting them in cross-legged position, they will feel discomfort and they will take that off. So if a child is not able to sit cross-legged till the age of 5 years, do not worry, that is normal physiologic phenomenon. You should not force them to sit cross-legged before 5 years. I receive a lot of complaint from teachers of school that this boy is not sitting. He's sitting in W posture every time, and I send them my child's photograph at the age of 4.5. So that's not abnormal. Now, how you would examine a child. Now this girl presented to me with intowing. How we examine? We ask the child to lie prone, and then we turn the legs outwards, and the knees are bent at 90 degrees, and first outwards and then inwards. Remember, when you are turning the leg outward, when a child is lying prone, you are actually doing internal rotation. And when you are turning the leg in when a child is lying prone, you are actually doing external rotation of it. So in this girl, you can see that angle of internal rotation, meaning that the leg when we turn out, it's 70 degrees, while this angle when child turns it in, that's an angle of external rotation is only 20 degrees. So there is a total range of 90, but there is more internal rotation. Usually by the age of 7 to 8 years, this range should be 45 degrees and 45 degrees. But if a child is having more of internal and less of external rotation, that means that intowing is coming from the hip joint. Okay, so this is known as hip intowing or femoral anteversion. So more internal rotation with the child lying prone compared to outward rotation. Now this can happen in contrast when a child is presented with external rotation. This boy presented to me just 2 days back, and if he's turning out. Now if you see this angle, his internal rotation is only 20 degrees, while external rotation, meaning that when I turn the leg in, is 70 degrees. So this boy is also having external rotation not from the feet but from the femur, and this boy is having retroverted femoral heads, in contrast to the child we were talking about before who has anteverted. So this is how you can make out whether this hip intowing is coming from the hip joint. Now, if you find that rotation are almost same at the hip while child is lying prone, then you can check at the next level. You go to on the tibia, and whenever you see the tibia from front, when child is supine, you draw a line around the patella, as you can see here, and then this long axis from patella should coincide with the second toe. Now here the second toe is pointing fairly inside. So this boy is having significant tibial intorsion. So usually we measure the tibial intorsion by measuring this line in supine. The patella long axis should cross to the second toe. But if it is crossing third toe, fourth, fifth, or in this case it is going completely outward, then the deformity is coming from tibia. We can confirm this finding by turning the child prone. By turning the child prone, we measure two axes. One is the thigh axis and the other is foot axis. This is known as thigh foot axis. In normal children, when there is no tibial intorsion, the thigh foot axis would be a straight line. But you can see in this boy, the foot is turning inside. So there is a negative thigh foot axis. So the intorsion or intowing is coming from either from tibia or from foot. Okay, is that clear, Dr. Agrawal, so far?
Yes, yes.
So from femur, we check the hip rotation. For tibia, we check thigh foot axis. And to differentiate whether it is coming from foot or not, we just make a child lie and we see from the bottom. So you can see that heels are straight, but the toes are turning in. So this is intowing coming from the foot. Now these all are different children. This is not same child. So in this child, both the hip and tibia were normal, but the feet were turning from the midfoot. So the intowing was coming from the toe. So this boy had Metatarsus Adductus. So now the key thing can happen that all these parameters are normal, and you see intowing only when child is walking. That can be due to some neuromuscular condition, and there you would need that can be a cerebral palsy, that can be because of hereditary sensory motor neuropathy or so on, and you may need to get a neurologist reference. But for orthopedic perspective, we do this 3 tests and find out from where this deformity is coming. For sometimes we have a combination of deformities and we like to do CT scan axial CT scan to confirm what is the magnitude coming from which joint more. But that is required when you need to operate upon them. Now, when we treat in-towing is again a different and vast subject and how we treat, but let's focus on how we examine time being. Let's come to flat feet now. Flat feet, again, this boy came to my clinic last week and I captured his images. The parents say that my child is walking with both the feet flat. Right feet is little more than the left, and we saw them from back, and both heels are little bit of going out or heel valgus. And when child was taken on couch, so when child is not weight bearing, you can see that on right side the arch is still flat, and on left side arch has reappeared. So when the typical finding of a flexible flat feet is when child is non-weight bearing, the arch would reappear. So the very simple examination, child is standing and then the second moment you take child in mother's lap and you will see arch has reappeared. That means this is not a rigid flat foot, this is a flexible flat foot. Now this is a combination of a rigid flat foot on right side and a flexible flat foot on left side in this child. So we took x-rays. What we do is we took stress x-rays and you see the talus, and on your left side, which is a flexible flat foot, talus is normal horizontally aligned, while on the right side the talus is vertically aligned. So this is a sign of rigid flat foot. We take stress x-rays to confirm our findings. And of course, rigid flat foot needs surgical treatment, while flexible flat foot have a tendency of self-resolution by the age of 5 years. And there are some families where they have flat feet running in the family. We term it as a familial flat feet. And familial flat feet may have some persistence of flat foot. But two things are very important, that if the children turn obese or very heavy weight, or if their heel cord is tight, they can produce pain. Otherwise, flexible flat feet, we do not treat them at all. Again, this is a child came to our clinic last week. You see the flat feet, and the moment child is on the mother's lap, arch has reappeared. So we have said this is a flexible flat feet, and it does not need any treatment. Sometimes you will also see a generalized hyperlaxity in these children. You can see the laxity parameters. The thumb is touching the forearm and so on. And these are the two important findings of differentiating a flexible from rigid. That reappearance of arch on non-weight bearing flexible flat feet, and heel cord is stretchable, as you can see on the bottom left figure. Whenever we see rigid flat feet, we see tendo-Achilles is always tight. So that is a key clinical examination which will guide you about whether it's rigid or flat or flexible. And whenever you find a rigid flat feet or flexible, always try to check the back for the evidence of neural tube defect. You will be surprised to see sometimes a sacral dimple or sacral sinus or sometimes a small tuft of hair, because whenever we see vertical talus, about 60% times they have associated neural tube defects. So always turn the child prone and check their back. Toe walking. Now, toe walking definitions are different in different literature. So first of all, let me define it for you. So when a child keeps on walking on the toes, that means that heels off, after the age of 2 years, without underlying neurologic condition, is termed as idiopathic toe walking. So a child who has started walking, say at 15 to 16 months, and he might do tippy toes till the age of 2 years, and then gradually it comes down, then that is not toe walking. Okay, that some children children's soles are not sensitized, and so they prefer not to bear weight on complete heels down. If you ask parents to brush their soles, some children they improve spontaneous. They need sensitization of their soles. But if they keep on walking with heels off by after 2 years, then we term it as idiopathic toe walker. This is also termed as congenitally short tendo-Achilles. Their heel cords are tight, And natural history, although not very well known, we know that 40% children can resolve spontaneously, and those who fail to resolve, we treat them with different hierarchy of treatments. So the question would be how to differentiate a spasticity from toe walker. Like how a 2 years old child who is walking on the toes is not a cerebral palsy child. So this is the clinical sign. This is known as the typical catch of spasticity, or the medical term is a tardive catch. You see how I examine the child. So we we give a jerk to the sole, and you can see the first catch, that is R1, and the second range R2. So this jerk or this catch we find in patients with cerebral palsy. Just like a tremor, when you first apply a brisk stroke, that is the catch that we will find in patient with cerebral palsy related spasticity. We will not find in idiopathic toe walker. So when you check them with a force, you will not find a catch. It will be the last range you get. But in cerebral palsy, we get first catch, and then we'll be able to do dorsiflexion a little bit more. So that is a key examination point we try to differentiate, because some patients are not much aware about the problems of birth history. There, this clinical examination sign helps us. So if I just make uh, a table how we differentiate. Uh, so this is a simple table that birth history would be normal for toe walkers and eventful in CP. On the milestones usually of toe walkers are well in time. In cerebral palsy there might be delay in milestones. As I mentioned that in toe walkers there is no spasticity or catch of dorsiflexion, while in cerebral palsy we find that catch. And toe walkers sometimes resolve by themselves, right? In cerebral palsy, these are progressive deformities with increase in height. The treatment differs in a way that for toe walkers, we give stretching, orthosis, and walking plasters. And surgery, if required, we tend to delay till skeletal maturity. While in cerebral palsy, we do not stretch them, because by stretching, we are increasing the spasticity. What we do is myofascial release. That's a technique used by our neurodevelopmental therapists. And then they also benefit from Botox injections that we usually do not use for toe walkers. So was that clear enough, Dr. Agrawal, for toe walking and cerebral palsy? I think.
Yeah, others also. We'll see in the question time if
Yes.
people have question related to this.
Right. Now let's come to the clubfoot. We all know that the clubfoot is very common, and the Ponseti technique of serial corrective plasters are fairly straightforward treatment. But whenever a patient comes to a pediatrician, it becomes it's your job to find out whether there is a real clubfoot, or just a postural deformity, or it's an idiopathic clubfoot, or it's a syndromic clubfoot. So these twins were referred to me, and in their antenatal scan they found to have Clubfoot. And on the first day the patient was referred to me, parents were very apprehensive that both kids are having severe Clubfoot. But when I examined them, you can see I could correct the deformity completely. I could do dorsiflexion to the full for both the children. And so these were diagnosed as just the postural deformity and not Clubfoot. They did not require any plaster treatment. So how you will differentiate a clubfoot from a postural deformity is the key thing is the dorsiflexion. So many times when it's a postural deformity, most of the time you can get full dorsiflexion. So it's a full dorsiflexion which you will never get in clubfoot. Clubfoot Equinus is the main element. You will not be able to completely dorsiflex. In normal feet, you will see multiple creases behind the heel. In club feet, you will see only one deep crease, and sometimes we don't see any crease at all. And this is the most severe variety of club feet. So this is 3 months follow-up of those children, and they did not require any treatment, and the deformities got corrected completely with just simple exercise mother performed. For real club feet or idiopathic club feet, Ponseti technique is gold standard, and we have everywhere across the globe we have found very successful results, and the treatment is pretty straightforward. Long-term outcome of this children is also very good. Now this girl, she performed this dancing, and there are many other such children. The problem is we have to be cautious. Not all club feet is idiopathic club feet. And for example, this baby when presented with club feet, I always ask my fellows to check their back, and she had this spina bifida occulta. So that's a gross spinal dysraphism she had. Again, this newborn with idiopathic club feet, we treated with Ponseti technique. It was absolutely fine. At 1 year, parents came back. The child, although the feet is corrected, child keeps the feet in turn. When we checked the foot, the size of foot was small, and the toes were clawing. As you can see here, the lesser toes. These are claw toes. And then when I tickled it, you can see there is active eversion on the affected side, on the normal side, but there is no active eversion on the affected side. So child could not actively evert the foot, and we should be aware that clubfoot can be associated with a concomitant peroneal nerve palsy or peroneal nerve neuropathy. And these patients would have very thin legs, and these patients may require multiple treatments in future, and they may need a longer bracing. So these are different from the idiopathic club feet. Now coming to our case, the patient has now kind of EMG was eventful right up to thigh, and we got an ultrasound that was showing the evidence of low-lying tethered spinal cord, although there was no external evidence of neural tube defect, and we required a surgery for her, and she had tethered cord with syringe. So simple looking clubfoot may have underlying neurologic issue, and a clinical examination where there is clawing of toes, there is dorsal dimple or sacral sinus, sacral dimple, their neurologist or neurosurgeon should need to be involved from day one. Again, I teach my fellows, when you see a single claw toe, rule out neuromuscular cause, and the parents needs to be informed from the outset. Arthrogryposis is very obvious, and the prognosis of these children is different than the idiopathic normal club feet. Now, just last month, one child came, my fellow took the history and said that having severe equinocaval virus neglected club feet. And when I asked the child to stand up, and I recognized that this child's limb is very short. And so we got an X-ray, and the child had absent fibula on the left side, as you can see. So this was a type of fibular hemimelia with club feet. So if you just keep on treating feet, but you have to look at the top. So with clubfoot, there are a lot of other things can also be associated, and pediatric colleagues can examine that from the first visit. Now, finally, I'll talk about DDH, and to diagnose DDH, all the pediatric colleagues, they are told that the flicks are very important. When you see the flick, the diagnosis is confirmed. But two things I'd like to tell you, that to appreciate a flick is a little bit difficult. It is not present in all the kids. So it's present in only in 30% children. So in 70% children with DDH, you may not find any flick. And the third thing is the flicks are not appreciable after 3 months, because the hips are become fixed, and their laxity has gone. So just to rely on flick will lead to underdiagnosis of condition. So I'll tell you the other clinical signs which can guide us about the diagnosis of DDH. The similar problems were existing in America or US for a couple of decades ago, and now they have come up with a clinical practice guideline, and these are really very uh, helpful guidelines, and Pediatric Orthopedic Society of India is also working on that, and we would also come up with that guideline which would be incorporated in pediatric curriculum later. So they have devised three things. The first is positive examination. Positive examination means clicking of the hip joint while examination. The second thing is warning sign, and the third is risk factors. So let's see them one by one. So when there is a click of entry and click of exit, or the kind of Barlow and Ortolani tests, uh, this is termed as positive examination. We have to take it as a positive examination. And as I mentioned, it is difficult to elicit after 3 months. That's first. Which are the three warning signs which are more easily appreciable to pediatrician? One is the first, the limited abductor spread. As you can see in this child, the abduction on the left side is fairly more than on the right. On the left side is less compared to the right side. So there is distinct difference in the abductor spread on one side, which should guide you that this can be a DDH on the left side. When you see unequal thigh folds, or when you see an apparently shortened extremity, so these are the other warning signs. So, or you see that apparently short femoral segment, so that is known as Galliage's sign. So these three signs are termed as a warning sign. One is limited abductor spread on one side, second is unequal thigh folds, and third is apparent short thigh segment. So these three are the warning signs, and the first positive examination was the click. And final risk factors: a breech baby, a baby with intrauterine crowding, or twin babies, or triplets, or a positive family history. These three are risk factors. Now, what guidelines or algorithm they have developed? So whenever a pediatrician examines a newborn and there is a positive examination or a positive click of entry or exit, the patient should be referred to pediatric orthopedic surgeon right away. If there is no positive examination, but there are positive warning signs, meaning that their abductor spread is limited on one side, there is unequal thigh fold, or there is thigh segment shorter, then again it warrants an urgent referral because there is high likelihood of having DDH. And the third and last is risk factors. If there is no warning sign, but there are risk factors like breech, female child, first female, and intrauterine crowding, then wait for 6 weeks and get an hip ultrasound. Or in India, we suggest that then bring them back at 6 weeks and then they check, or refer, and we'll just screen them for their abductor spread and other signs. Or if you have available USG, you get it USG at 6 weeks, because by that time the laxity part of the hip joint will be gone and you can have a true hip examination. Why early detection is important? That is very important. Because for the first 6 weeks of life, there is effect of maternal relaxin hormone, and the hip can move in and out little bit. That is okay. But between 6 weeks to 6 months, if we find out DDH, we can treat them without any operation. We can just treat them with Paulich harness. But when it comes beyond 6 months, that child needs surgical treatment. Unfortunately, in India, 90% of children with DDH, they present to orthopedic surgeons after 1 year. That is such an unfortunate event. While I was talking to one of my colleagues from Austria, they do not see neglected DDH because that's a universal screening program going on there. So they don't see neglected DDH at all. But we see 90% of patients after they start walking. Now, there's this 4-month-old baby with ultrasound diagnosed DDH. On right side, you can see the hip, the ball is out of the socket. We can just treat with, this is the harness, the simple belt, and mother can hold the child in the left, and this hip got neutralized, and with a 6 weeks of harness application. So this child does not need any treatment. In contrast, if this child who presented for the first time to me at the age of 8 years with short limb gait, I required to do open reduction, acetabular osteotomy, shortening. So it's a great magnitude of operation required to make this child gain normal anatomy. And as the age of presentation of DDH children increases, the rate of avascular necrosis or complication keeps on increasing. And that is why it is important to catch them early. And for catching them early, our clinical examination should be robust. And it's not only orthopedic surgeon, but pediatricians are the first person where they screen this children. So I think I would stop here, and we should give time for question answer. Thank you very much.
Thanks a lot. Uh, I would request colleagues to post their questions on the chat box. As they are posting their questions on the chat box, can we have few lines on the examination for scoliosis in children?
Yes. So the in scoliosis, whenever usually there are two types of patients. The first is the children they are presenting fairly early in their age, and that's known as early onset scoliosis. The main presenting thing is mother reports that there is a bump on the paraspinal region on one side compared to the other, or sometimes when the child sits, it is a more prominence of bump there. So whenever you see a paraspinal prominence on one side, this should they should guide you about the presence of scoliosis. This can become more prominent when you ask a child to touch the toes and turn forward, because that makes the rotation more prominent. So that's how we diagnose. Now, for adolescents or older children, when there is a scoliosis, they would also have imbalance in the shoulder. One shoulder may have gone little up. They may have abnormal waist creases. And for young children, when they have a bit of scoliosis, you should always check three things. One should check spinal dysraphism. So always spread the buttock folds and see whether there is any sacral dimple or sinus, because 35% times they have either spinal dysraphism or congenital cardiac anomaly or congenital renal anomaly. So whenever I see a child with congenital scoliosis, I advise 2D echo. I advise abdominal ultrasound to rule out renal anomaly, and the spinal cord MRI to rule out associated these features. Another thing is with scoliosis, there can be neuromuscular scoliosis or idiopathic scoliosis. You have to check neurology, whether there is spinal cord compression or not. There is spasticity in the extremity. But key thing for younger children, whenever you check them upright, the deformity will be less prominent. When you ask them to turn forward, then the deformity would be more severe. Get an X-ray and confirm, and then we check whether it is a rigid scoliosis or flexible, whether it is a congenital or idiopathic scoliosis. Then based on that, we treat them.
There is a request to demonstrate reduction of subluxation of the elbow, and a few lines on the same.
Yes. So that is, the term is not right. It's not subluxation of elbow. It's a subluxation of radial head. So that's a pulled elbow or nursemaid's elbow. So that's very common. Why it happens in first instance? As we know that maternal relaxin hormone passes fetal circulation in about 30% children, and they remain lax for till the age of 5 years. And those children, when they are playing, sometimes we see parents are holding their wrist and they are playing with children, and there they accidentally twist the forearm, or sometimes child is sleeping in the bed and then they turn and they pull the elbow. So we term it as a pulled elbow. Uh, Historically, it was seen by nursemaids when they were doing massage or malish. They used to make this problem. So what I have seen in my practice is we have seen in 80% children, we reduce this by supination maneuver. Now, what is supination? Let me call my fellow in, and I'll demonstrate on him. Just a moment. Give me a moment. And in 20% we see with a pronation. Chinmay, तो अंदर आएगा एक मिनट. So in 20% we see with a pronation maneuver. So what you need to do, I'll show you in a moment. I think it's about. So let's see. So assume that he is a patient and always flex the elbow and keep one thumb on the radial head, and usually their arm will be pronated like this. So turn it supination. So when you turn supination, the palm should face up, and that corrects this in 80% children. 20% children, what we do after doing this, we turn it completely like this. So that's known as hyperpronation. So what happens, you have to put your thumb along the radial head here, and you will feel a pop of reduction. And so I try supination maneuver first, and in 80% children, it is the supination maneuver which reduce. If it fails to feel that pop, I would turn the forearm completely in pronation. We do hyperpronation, and that happens. That the pulled elbow would be reduced. And many a times we teach parents, because in 15% children it can happen again and again, but it never happens beyond 5 years, and it has no long-term side effect, or there's no long-term problems with pulled elbow.
For the benefit of our delegates, can you please repeat that clinical test for toe walking jerk?
Right. So that is known as a tardive catch. What we do is, the child is lying on the couch and the knee is extended, and you with the palm you just give a sort of stroke on the foot, kind of midfoot. Now assume that this is a foot, so you give a stroke. Whenever it is cerebral palsy, we see a catch. So at certain range the foot stops, and then again you do, so there will be further dorsiflexion. So that is first catch, that is known as the catch of spasticity. But when we see toe walkers, there is no catch. Catch is actually when a child is walking on the floor, what happens with that localized stretch reflex, that is the catch. But in toe walkers, there is no neurologic element. So you will be able to do it. There will not be catch. There will be only single range. While in cerebral palsy, you will get two range. So that's how you differentiate.
There are two questions on DTH. One, what is the specificity of the click sign? And second, can USG hip be done as a screening examination, and at what age?
Yeah. So the specificity, I don't exactly know the number, but many a times there can be a false positive click. There are iliotibial band, and there are some muscles. When you do abduction and adduction, the muscles move over the greater trochanter and can give you a false click, or what we term as an extra articular click. So not all the clicks are DDH. There might be because of the movement of the tendon over the greater trochanter. So that is one. The universal screening is not cost effective, because if you see, there's less expertise to do this test. The sonologists will become very busy. The second thing is, we can advise ultrasound if there are the risk factors like a breech baby, or a previously born DDH child, or mother or father had DDH, or there was intrauterine crowding, coupled with this clinical test, like your abductor spread is unequal, or the thigh folds and the limb segment. Those signs are late signs to come. But unequal abductor spread is a very important clinical sign we see in almost all the patients. So at-risk children, with positive clinical examination, one can get ultrasound. And in some, when you have doubt, it's not unreasonable to get ultrasound, but you should find out who is a good sonologist. It's not difficult technique, but you should find out and train sonologists to diagnose them. Now, what is happening with the radiologist? The softwares are also there, so they just have to take a neutral image, and that software uh, will tell them that whether what grade of DDH it is. That's known as a graph method. So that is very easy. I have trained a lot of radiologists in Ahmedabad, and then after some time they came and told me that this is graph 2B, and I told him, "Well, I have not taught you that," and he said, "We have now got the software which which tells me that." So yes, ultrasound can be done, but universal screening is not possible.
Dr. Girish has a series of questions, so I would hand it over to him to go ahead.
Yes.
Dr. Girish, you are unmuted. Yes, he is unmuted. Dr. Girish? Yeah. Can't hear you. Dr. Girish, come again.
You can type in the chat box. You can have it.
Savar, could you take up why BDH wait for 6 weeks to do ultrasonography?
Yeah, why we wait for 6 weeks is till 6 weeks this maternal relaxin hormone can give you a false positive ultrasound. What we measure in ultrasound is an alpha angle. So it's an angle of acetabular dysplasia. So till 6 weeks, that the hip is kind of immature, and the acetabular angles would come suboptimal. But that suboptimal angle would not mount to consider it as a DDH in presence of normal clinical examination, and that's why if we find abnormal ultrasound at say 3 weeks, so we will not start treatment, but we will repeat ultrasound at 6 weeks. By that time, the hip immaturity and the effect of maternal relaxin hormone will go off, and that at 6 weeks finding will be more reliable to start the hardness treatment. Was it clear? Because of intrauterine posture, acetabulum would look dysplastic. But the moment child is born, their leg will start spreading, and by 6 weeks they will attain what normal hip alignment is. So at 6 weeks, if still there is persistent dysplasia, means that angles are less, then we would start treatment. Not at 3 weeks if someone gives you an abnormal ultrasound report.
So it's not wrong if we can definitely send for an ultrasonogram in the first 6 weeks, but we have to wait before you confirm till 6 weeks, right?
Yeah. So if you have an access to pediatric orthopedic surgeon, and you say you have done an ultrasound at 3 weeks, and it shows that that alpha angle is less, but then orthopedician would examine. If he finds that there is restricted abductor spread, or there is abnormal thigh crease, or there is some click, then there is no harm, there is no point in waiting. But this question comes when we have done ultrasound for screening purpose, or when there was a history or a breech baby. So in those cases, when ultrasound is done at 3 weeks are showing little bit immature hip, we tend to wait because by 6 weeks the picture would be clear. Many times, an ultrasound at 3 weeks would normalize by the time by the 6 weeks. But if there is clear-cut clinical positive warning sign, we have started harness treatment from 3rd week of life also. Could I answer your question? You can definitely do an ultrasound, but we would start treatment only if there are positive clinical examinations.
Dr. Girish, are you unmuted? You can try again.
You
No?
can, in chat box, he can write it.
Savar, could I pass a comment?
Sure, certainly, yes.
Sir, Maulin Shah, you said about the sacral dimple. We find it so common. Somebody has a clubfoot and has a sacral dimple. I don't think we can jump to the conclusion that it is the culprit. Sacral dimple is such a common thing. A pathological sacral dimple is abnormal, I agree. Could you
Yeah.
be more elaborate? Otherwise, everybody will find a sacral dimple and say, this is the villain.
Yeah. So what I wanted to tell you is, many a times an idiopathic club feet will not show the sign of neurologic club feet from day one. Like, what are the signs of neurologic club feet? That they fail to evert the foot, they remain clawed, and so there is, when this parents needs to be told from the outset that if you have a neurologic clubfoot, then you will need a longer time brace where there are higher chances of recurrence because your motor power is not good. There will be the changes in the girth of calf and all. So this we have learned after experience of lot many years, because parents can shout on you that your plasters have made this change in the shape of leg. So that is a practice at our center, that you check uh, the patient's back every time. Now, if you find just a dimple and normal looking feet, but you keep that dimple is there in your examination point. If any time you find the child's strength is not good, you will go for ultrasound. Not in the absence of symptoms. At the same time, sacral dimple is different than sacral sinus. If you have a sinus or deep going, and sometimes sometimes there is subtle change in the size of sole. So whenever a fellows or they see sacral sinus, they come back on the limb and examine the size of calf, girth, and size of foot. Because, so in nutshell, not all sacral dimples go for ultrasound, but sacral dimple with the signs of neurologic clubfoot, that will go for ultrasound. The sacral dimple without signs of neurologic clubfoot will be observed. We keep that finding in our mind, and that is highlighted in the first clinical examination. So whenever it comes in follow-up, if at all there is sign of neurology, we'll get ultrasound. So that you are right that it is very common. One of my grandmother told me that I say that your child's foot looks little smaller and there is sacral dimple, we should get an ultrasound. And she told, sir, मेरे 6 बच्चे हैं, 6 में से 5 को डिंपल है, अभी किसी का हमने नहीं कराया. So she was such a smart grandma. I said, you are right, but as this child has different in the size of the foot, I would like to do it. And she turned out to be normal. So the grandmom was right.
I think the location of the dimple also is important. If it is more than 2.5 centimeter away from the anal verge, then also it is important. And I think Dr. Radha is referring to those pilonidal sinuses, which are apparently are covered with skin. And if you stretch it open and you see that the floor is covered with this intact skin, then probably they are not pathological.
Yeah. Another thing what we have observed, the dimples which have associated underlying dysraphism, sometimes they have a lot of blue patches around. That is one, and their cleft is deviated. Sometimes they have deviated cleft. So
Yeah.
this is amalgamation of all these clinical findings, and yeah.
Can you hear me now, sir?
Yeah, sure.
So, Dr. Shah, thanks for a wonderful presentation.
Thank you.
I wanted to ask about intoing. You said about those various maneuvers that we use. What I follow in my practice, it's a simple maneuver. Tell me whether I'm right or wrong. Metatarsus adductus is very easily picked up just by looking at the foot. When it comes to differentiation between femoral anteversion versus internal tibial torsion, look where the patella is pointing. If the patella is pointing straight ahead, then we are dealing with internal tibial torsion. If it is pointing inward, then we are dealing with femoral anteversion. Am I right?
Yes, right. Many a times, what happens when a child has come to you with in showing, say, before the age of 6 years, there might be a combination of all this. So if a child's patella is facing inward and you say this is coming from hip, you now don't examine tibia, it's not right. Like there you have to turn the child prone and there might also be a tibial component. So the multiple things can coexist, that's one. Uh, the other thing is a child who is compensating from the hip or tibia. Say for hip you can see from patella. But what if tibia is interned? Tibial intorsion is there. Many a times these children have flexibility or arches are flexed, so they try to claw when they stand. So it will be misjudged as a as metatarsus adductus when child is weight bearing. A metatarsus adductus should be seen a non-weight bearing from the bottom, and if this is turning in, because when a child is bearing weight, because their arches are legs at times, they try to grip the ground by turning the toes in. So that should not give you a false impression that this is metatarsus adductus. So metatarsus adductus, you examine non-weight bearing from the sole, and tibial, if patella is turning in, then they were right that femoral anteversion is there, but do not fail to check tibia. Turn them prone and check the thigh foot axis. That will give you clue about the tibial angle, and look at the sole, and that will give you about metatarsus adductus. So the key thing is all these parameters are mainly physiologic. Uh, I very seldom required to operate upon these patients unless
Yeah, that
there
is
is.
what
So the question
that was
is
what I
where.
was about to come to. I remember in your last lecture, I had asked a question that if at all you find some abnormality, would you operate? And you said rarely ever. So I always, from that day, I thought that this is just an academic exercise. What is the big point in spending so much time on doing all these tests when at the end of the day, you're not going to operate on it?
Agree with you. But now I tell you the other part of the story, that there are some patients like say patient who had flatfeet uh, before, and now flatfeet was corrected, and then and tibial intorsion is a part of clubfoot sometimes. So there are patients who were operated on the feet for 3-4 times and still the foot is pointing in. And one of my fellows referred this case to me and they failed to look at tibial intorsion. And I said that this tibia is turning in, you are operating on the feet. So you better correct the tibial torsion and then that deformity got corrected. So yes, physiologic things are not problematic, but we see a lot of children with subtle cerebral palsy, subtle dystonia, and some underlying foot deformities that there we need the treatment. And then certain religious practices, like they have to sit cross-legged and the child is not able, a girl is, I remember there's a 9-year-old girl, very religious family, they have to sit down cross-legged for prayers, and she is not able to sit. She sits in W posture, and family is significantly unhappy. And someone did a femoral osteotomy, and still she is sitting in kind of, she is not able, I mean, someone did tibial osteotomy, thinking that this her turning in is coming from tibia, and they failed to correct at right level. So yes, this is a futile exercise, but for us, the patients come at tertiary center when they are exhausted with all other issues. But I agree with you that in 90% times we do not need to operate upon them.
Sir, could I just intervene? Girish has said if the patella was looking inward or outward, it's a problem of tibia. Maulin, you're saying if the patella was pointing inward or outward, it's a problem of the femur, which is correct.
Yeah. Yes, Dr. Girish, what do you think? Then I'll tell you what I think. I think we were talking the same, isn't it?
No. Girish was saying if the patella was looking inward, it was a problem of the tibia.
No. When patella is turned in, then the whole femoral segment has turned in. So that is hip internal rotation.
Yeah.
I thought we were thinking
on the same page. Yeah. Can you recall some pathological causes of intoing which needed intervention? I mean, we have discussed at length about the physiological intoing. So,
yeah.
what are the important DDs where you find pathological cause, both in towing and out towing?
So outgoing is we see in some patients with metabolic bone disease. Outgoing is common because some patients they widen their legs and turn the extremity out. While doing this, they make their base of support broader, and that helps in balancing. Now, as the age advances and as the metabolic parameters normalizes, still because of the earlier on they were doing this, their bones are turned outward. So that we see in some metabolic bone disease. Secondly, that we see in some cases of myelomeniingocele also. In myelomeniingocele, they try to bring their hamstrings in front. Now that's an orthopedic thing, but so in myelomeniingocele they have a lot of tibial extorsion, and some of there we need to correct it. Cerebral palsy is the one where they have their motor milestones are extremely delayed, and so there is persistent femoral anteversion leading to persistent intowing, and they can have a compensatory tibial extorsion. So this exercise is very important when we treat cerebral palsy children because some of them may have femur turned in and tibia turned out. So we turn femur in and femur outwards and tibia inwards. So that's an we have to what that's known as a torsional malalignment syndrome. So cerebral palsy another reason. Some patients with hereditary sensory HSMN where they have long-standing inversion, they may have associated tibial intorsion. Then some children have, as we see, exaggerated physiologic Genu Varum or persistent Genu Varum. We see some patients with persistent tibial intorsion. So the tibial intorsion till the age of 5 years is normal, but some patients have persistent significant intorsion to 6 years, 7 years, 8 years, and there they flip their legs while walking. So these are rare things. And Clubfoot patients may have torsional malalignment also. So these are the conditions where we operate.
Savar, could I ask a question?
Please go ahead. Yeah.
Yeah. Now, now in from books mention that idiopathic scoliosis is so common in adolescent. I've never made a diagnosis. Does it mean I'm missing them?
It's not so common. In Indian population, I think the incidence is less, and the families they come to doctor pretty late. You know, they come only if the deformities are significant. In Western world, the young girls they want to wear a low waist jeans and as the incidence is high, they have scoliosis screening programs in the school. So very subtle degrees of scoliosis they identify earlier on. As we do not have that scoliosis screening programs, we come across only very severe scoliosis. Now the key thing is when a scoliosis is less than 40 degrees uh, at skeletal maturity, say that for a girl if it's 13 years her scoliosis is 40 degrees, then it will not progress in the life. But when it is more than 40 degrees, it will keep on progressing even though they finish their growth. So the problem is they're twofold. As there is no universal screening, less patients come to us, and Indian children come to us only when the deformity is significant enough to warrant attention. Now the scenario is changing. They are more cosmetically what you say aware about it, but it's not that common. We are reading the Western books. There it is very common. So I think your examination is not at fault. You are a good clinician. Yes, sir.
So can I ask a question? So when it comes to Genu Varum and Genu Valgum, I see many pediatric orthopedic surgeons suggesting exercises.
So if I
intuitively, I feel that it is a ridiculous exercise. What is your contention on this? Physiotherapy is genuine.
So I could hear your question in pieces because it was cutting the sound. But if your question is it right, you were asking physiotherapy for Genu Varum and Genu Valgum is your question, Dr. Girish? I could not hear it
Yeah,
clearly.
the white was breaking, so it was
So
difficult to.
can you type in chat box? I think he was asking whether a physiotherapy is needed
Yeah,
for.
I also heard in pieces, so I can't stitch them together.
Okay, let me answer this. Whether there is role of a brace or a physiotherapy for the Genu valgum or Genu varum, the answer is no, because these are the physiologic alignments and they have tendency of self-resolution. Uh, some people are advised a 3-point brace to correct it, and as the deformity corrects by itself, they take credit of it. But if you leave them alone, then also they are going to improve. That's one thing. And there are some ortho tests, they claim that because of this Genu varum or Genu valgum, their weight bearing is happening abnormally and it will hamper their walking. So that is not true. I have never prescribed a 3-point brace for any patient. Yes, there are some evidence that we can use it for a unilateral deformity. So we have patients where there is only one side Genu valgum and one side is straight. And in there is a limb length discrepancy and abnormal traversing of forces across. There we have used braces, but not for bilateral cases. And people are saying that overweight or weight bearing can be detrimental. That is based on the finding that all the Blount's disease patients in African countries, they have found their body mass index fairly higher compared to the normal peers. But in India, the Blount's disease is fairly uncommon, and so we do not let them keep them away from weight bearing if we found Genu varum. The other factor is we are not able to differentiate an infantile tibia vara from Blount's disease just based on X-rays, because there are a lot of parameters described on X-ray which might suggest a Blount's disease or a physiologic tibia vara, but none of them is right. We see a lot of patients falling on Blount's category, they get straight by themselves, and the one on the benign category, they end up into Blount's. So what is most important thing is you have to periodically observe these children, and if their deformities are increasing, then they need intervention, and this progression can be seen by asking them to send pictures every couple of months, and whenever needed you get a full length standing neutral x-rays. No role of physiotherapy, no role of bracing uh, in routine patients of Genu varum and Genu valgum.
I think with this, it's time to thank you profusely, Dr. Maulin. And I personally enjoy your talks to a great extent, and I'm a big fan of yours. And thank you for being here, sparing your time and sharing your experience and knowledge with us. Thanks a lot.
I have not talked about brachial plexus palsy because I can keep on talking for days together. But whenever I'll be very happy to talk about it in future if you.
Sure.
Savar, can we have a session on brachial plexus palsy by Maulin sometime?
Bilkul, absolutely, yes. In future, we'll plan that. Okay.
Because probably we are quite backward on about it. Modern things could have come in. Maulin will be definitely telling.
Sure.
Yeah.
So,
Sure, sir.
thanks everybody for being here. Now it's time to end the meeting. Thank you so much.
Thank you. Yeah.